Thank you, Kathy, for that. Good afternoon, ladies and gentlemen. My qualification for speaking to you today is principally longevity. There are not many of us around now who were consultants before the founding of the Institute in 1968. However, being 84 years old does have drawbacks. I hope that's not relevant. My remit today is to look back on the situation in the specialty in Ireland in the late 1960s. John Murphy's already given a certain amount of material which is already ready for me to say, but I'll try not to overlap too much. The first slide was put up to emphasize the paucity of consultants in the Republic at the time outside the main centres in Dublin, Cork and Limerick. I was interested this morning to notice Dr. Gorey talking about midwife training, and she listed the places in the early part of the 20th century where midwives could be trained. The same three, Dublin, Cork and Limerick. As John Murphy's mentioned, many counties, the obstetrics were run by the county physician, and if it was decided a caesarean was necessary, he called in the county surgeon. The map highlights the fact that outside the three main cities, there was a dearth of consultant-led maternity units. Many deliveries, especially private, took place in the small private nursing homes or in small GP units, none of which had proper backup facilities. The medical missions of Mary in Drogheda, the regional hospital in Galway, and Portiuncula in Ballinasloe were the only places which had two obstetricians. There were single-handed consultants in Castlebar, Sligo, Waterford, and Wexford. You'll note that in the whole centre of Ireland, the only consultant unit was Portiuncula. Apart from Galway and Drogheda, none of these peripheral units had any paediatric support. The patients of our speciality are almost entirely female, yet, as in many countries, when I arrived here, it was almost entirely male, as illustrated in the slide. The only two female consultants in the initial institute were Lily Troy in the Coombe and Sarah Lahan in a single-handed post in Castlebar. With the immense change in the sex ratios in the specialty in recent years, it is fitting that in its Golden Jubilee year, the first female chairperson should have been appointed. And I take this opportunity to congratulate Cleona Murphy and to wish her a successful term of office. This picture has already been up, but just to draw attention to the start of the Institute in 1968. That was under the chairmanship of Professor Alan Brown, but it was only the beginning of the development of the Institute. Over the next 7 years, there were numerous meetings between the officers of the Institute and the college officials. There were disputes about our title, and someone asked a question just a moment ago about this. The college wanted to incorporate us as a faculty, but the people involved from our part of the Institute felt their independence within the college needed to be emphasized. This applied especially to the question of dealing with outside bodies, such as the Department of Health and the Royal College in London, as well as to matters of financial control, which of course are always important. It was 1975 before the Institute was finally incorporated into the college, and even after that, there were many matters to be sorted out, particularly concerning the supervision of postgraduate education within the country and the maintenance of standards within our specialty. The Institute is, of course, a national body, so it's disappointing to note that to date, there's been no chairperson from either Cork nor Limerick. John put up a slide of the coup in 1965, and I actually chose some figures from the Coombe Hospital in 1966, their last year in the old hospital. And I've given beside them a few figures from 50 years later in 2016 to give some ideas of comparative values. Firstly, the huge difference in perinatal mortality, and I hope the next couple of slides will give some indications as to why. And secondly, the massive difference in caesarean section rates. It's interesting to note the Hollow Street report for that year, Kieran O'Driscoll, as master, suggested that the optimum caesarean section rate should be 4%, rather different from today. The obstetric issues, I've mentioned pediatrics. There was virtually no pediatric support in the peripheral hospitals, and even where pediatricians were available, the speciality of neonatal pediatrics was barely in its infancy. The ability of the pediatricians to keep premature babies alive and well has been essential in allowing obstetricians today to safely deliver at-risk babies at much earlier periods of gestation than was the case 50 years ago. John has mentioned the high parity in the Coombe, and that was universal. Obstetric ultrasound. In my opinion, this was probably the greatest advance in 20th century obstetrics, and it had been pioneered very recently by Professor Ian Donald in Glasgow. It was still in its infancy and was being greeted with quite a lot of skepticism in many quarters, and was certainly not generally available. Some of the disadvantages of that fact were there was difficulty in sorting out uncertain dates, which were extremely common. There was a frequent failure to detect twin pregnancies. There was less information about fetal well-being antenatally, and most fetal abnormalities were not detected antenatally. Induction of labor. Prolonged labor first, perhaps. Prolonged labor was frequent. Only a short time before I came here, my boss in the UK had written a paper on the outcome of labors lasting more than 3 days. The active management was pioneered here in the very late 60s by O'Driscoll, Jackson, and Gallagher. Their first paper on this, which made worlds of significance, was published in 1969. They described the regime as, quote, military efficiency, but with the human face. Personally, I'm skeptical of the ability to mix these two radically opposed approaches. Induction of labor is the uncertain dates made timing of induction difficult. The lack of prostaglandins made the risk of failed induction in cases with unfavorable cervix a deterrent to induction, although it appears that in some hospitals at least, it was not infrequent to rupture the membranes, but not necessarily to proceed to caesarean section if labor did not follow. Because of the absence of electronic fetal monitoring, the use of intravenous syntocinon required close personal monitoring, sometimes for a long time. And I recollect when I was in Oxford before coming here, that if a patient was on intravenous syntocinon, the house surgeon had to sit with his hand on the abdomen throughout the time that she was on this drip to detect the contraction and listen with the penile stethoscope to the fetal heart during and after the contraction. If the patient happened to be private, that was the job of the registrar or even senior registrar. Sorry. Pain relief in labor and for delivery. Epidural anesthetic or anesthesia had been widely used for pain relief in labor in the United States for quite some time. But it was only in 1969 Now, Dr. Dermot Kelly, again in my own hospital in Ballinasloe, commenced the trial of continuous technique, and it was some time before first the Rotunda and eventually most other units adapted this method of pain relief during labor. Remember, the previous slide showed a rate in the COOM in 2016 of 38%, rather different from zero. Before the introduction of widespread epidurals, if an anesthetic was required, it was virtually always a general anesthetic, often given by an obstetrician rather than by an anesthetist. And if you remember, of course, that general anesthetic at the end of a long labor is a lot more dangerous than many other forms of giving many more situations for using it. Many patients at that time, especially private, liked to be asleep their delivery. I remember a cousin of mine, I asked her, she was booked in one of the Dublin hospitals, and I asked her why she'd booked a particular consultant. And the answer I got was, because he put you to sleep quickest. Resuscitated immunization, John has mentioned that. It was a trial that Stanley Hewitt was carrying out on the use of gamma globulin, and a letter appeared in one of the major world journals referring to research being carried out in New York, Liverpool, and Ballinasloe, and other world centers. Sorry, I lost that bit. Antenatally, the detection of fetal distress was difficult. Antenatally, there was no ultrasound to measure amniotic fluid volume. Again, one of the previous slides showed that amnioscopy was being used in the Rotunda, and in fact, in 1966, they carried out over 300 amnioscopies, none of them before 36 weeks. Occasional amniocentesis were also being done to try and find what the life flow was like. In labor, there was no electronic monitoring of the fetal heart, so assessment of fetal distress had to be on purely clinical grounds. Staffing levels sometimes made it difficult to monitor the fetal heart adequately. Symphysiotomy was still being done very occasionally, always in patients who are likely to have many further pregnancies. Family planning, that's been dealt with very adequately by Mary Daly. She mentioned the fact of the pill being used for this purpose. It's, as John says, always used for period regulation. Lack of computers. Imagine trying to get out annual reports or research papers without any form of electronic help. Gynecology. I noticed so far we've only heard about obstetrics. We haven't heard gynecology mentioned. We're called obstetricians and gynecologists, but all the talk has been on obstetrics. And I spent all my time to date talking about obstetrics, and it's probably a fair reflection of the relative status of obstetrics and gynecology in Ireland in 1968. When I was leaving Oxford to come here, my boss there said to me, Dublin obstetrics are good, but they are way behind in gynecology. In the UK, consultants were mainly gynecologists who also supervised obstetrics, whereas in Ireland, there were obstetricians who did some gynecology. On the slide, I've just listed some of the problem areas. The emphasis on obstetrics rather than gynecology meant that there was a shortage of gynecological surgeons with higher training, and so the surgical treatment of gynecological cancer was very limited, and neither radiotherapy nor chemotherapy were well developed. Infertility treatment was extremely limited. There was, of course, no IVF nor other methods of assisted reproduction. Laparoscopy was not yet available, and relatively few consultants were trained in complicated vaginal surgery. Cervical cytology was in its infancy in Ireland, and there were certainly no systematic screening programs. And colposcopy was yet to be pioneered by our previous speaker, Professor Murphy. There were no intravaginal drug treatments of menstrual problems, and other drug treatments were mainly unsatisfactory, so the incidence of hysterectomy for bleeding problems was very high. Although the fact that such a procedure was also 100% effective as a contraceptive measure was not irrelevant. Medical legal was just mentioned a few moments ago. We've been dealing all the time, or I've been dealing all along with the difficulties of practice 50 years ago. But medical legal was the one area where things were easier, at least for the patient, for the doctor. There were few medical legal cases, and as a result, the annual subscription to the Medical Defence Union in 1966 was £6. £6 compared with the many, many thousands nowadays. Ladies and gentlemen, thank you for your attention.